Hello, everybody, and welcome to September's edition of St. John's Cancer Institute's Be Inspired Speakers Series, Bone Health and Cancer Treatment. My name is Jean Goldsmith, and I'm a Director of Development at St. John's Health Center Foundation. As many of you know, in January of 2021, the Cancer Institute's name changed to St. John's Cancer Institute. The licensing agreement allowing St. John's to use the name and likeliness of John Wayne on the Institute and the fellowship program expired at the end of 2020. And the name is in change. I said this wrong. The change is a name only, and it will not impact the Institute's operations in any way. And the fellowship program will now carry the name of the physician who founded the Institute and be called the Donald L. Morton Complex General Surgical Oncology Fellowship Program. St. John's Cancer Institute will continue to provide excellence in research, education, and cancer care through innovative clinical trials and laboratory research, the education of the next generation of surgical oncologists and scientists, and of course, state-of-the-art treatment for our patients. Going forward, we will expand and deepen our focus of our main pillars of cancer research: immunotherapy, molecular medicine, and genomics. Before we get started today, I have a few housekeeping items to share with you. We would love to hear from you and are hoping that you will ask questions during this webinar. As you will notice, everybody but the presenters are muted so that we will all be able to hear them well. In order to ask questions, you will need to use the chat function on your screen. The chat function is located at the bottom of your screen, and it looks like a thought bubble. We will see your question and ask the physician. If we do not get to your question during the webinar, we will follow up in an email to you with the answer. If you have a question after the webinar, please email us and we will get the answer to you. You can communicate with us by responding to the emails that we have sent to you. We have a very interesting hour in front of us today, as we will hear from two endocrinologists and a rheumatologist who focus on bone health and osteoporosis after cancer treatment. They are clinicians and researchers and work closely with St. John's research labs to make strides in the treatment of bone disease. I'm very honored to introduce the panel today. Our first panelist is Dr. Rose Lynn. Dr. Lynn is board certified in endocrinology and specializes in the care of diabetes, endocrine, and metabolic disorders. She has been in practice in Los Angeles for many years and moved her practice to Santa Monica, where she lives with her husband and her young children. Dr. Lynn has a particular interest in diabetes, but enjoys seeing all general endocrinology patients as well. She believes in a working partnership with her patients to achieve optimal health. Dr. Lynn, what excites you about your work in endocrinology, and what drew you to specialize in it?
Certainly, thank you for that great introduction, Jean. So I did my training in internal medicine residency, and during that time I really was thinking I would go into either cardiology or perhaps endocrinology. And I'm really happy that I did go into endocrinology. It's really a very fascinating subject. You really learn a lot about the physiology, about the different pathways of these hormones and how much they really affect everything that goes on and how we feel and regulating our normal body processes. As a career, as a physician, as I've gone into practice and as I've been in practice, it's been really fulfilling also to develop really long-term relationships with the patients and the people that I work with. I would say majority of endocrine conditions are really chronic, and so there's a lot of monitoring, there's a lot of follow-up. And so again, coming back to those long-term relationships that you're developing, and you really get to know people well. And it's, again, very fulfilling.
Thank you very much. It is incredibly interesting. It just really, every aspect of your health is affected by your endocrine system. And so you get to see everything, which is fascinating, I'm sure. Our second panelist is Dr. Frederick Singer. Dr. Singer is a professor of endocrinology and the director of Endocrine and Bone Disease Program at St. John's Cancer Institute. He specializes in metabolic bone disease and has long-term experience in osteoporosis, which develops in cancer patients and individuals with bone metastasis. Dr. Singer has been a professor of medicine at both the University of Southern California and at the Geffen School of Medicine at UCLA. And I believe he also taught Dr. Troum, another of our panelists today. Dr. Singer, there has been incredible changes in medicine in the past 25 years with new drugs and surgical techniques available. What are the major changes that you have seen in the field of bone disease?
Well, I think the development of bone density instruments has been an incredible advance. Otherwise, we just had an X-ray, which is sort of hard to interpret, except if you see a fracture. So bone density has been an incredible advance. And then, of course, slowly, a variety of medications have come through the FDA and approved. And in general, it's nice to think that anyone with a cancer who has a question about their bones, we can do something beneficial for essentially everyone, depending, of course, on what the problem is. If we think about osteoporosis, we can really help essentially every patient. So I think that's been an incredible advance over, a period of 25, 30 years.
Great, thank you very much. And we look forward to hearing today about the things that you were working on. Our third panelist is Dr. Orrin Troum. Dr. Troum is board certified in internal medicine and rheumatology and was a past president of the Southern California Rheumatology Society. Dr. Troum is a master of the American College of Rheumatology, a designation conferred on members who have made outstanding contributions to the field of rheumatology. His clinical research focuses on psoriatic arthritis, spondyloarthritis, rheumatoid arthritis, osteoarthritis, osteoporosis, and metabolic disorders. He has more than 30 years of clinical research experience, participating in over 100 clinical trials as a principal investigator. Dr. Troum, there are a number of different specialties that work with patients with osteoporosis. We have two endocrinologists on the panel, and you're a rheumatologist. Can you describe the different approaches each specialty has on this process?
Thank you, Jean, and it's my privilege and pleasure to participate in this panel. I have to start first. You mentioned that Dr. Singer was my mentor and a former professor of mine at USC, which is when I first met him, probably about 40 years ago. Fred, if I'm right about that, you can let me know. But I feel a special attachment to this group because my wife is also an endocrinologist, who I also met at LA County USC. But to answer your question specifically, I see patients that have other autoimmune connective tissue problems that have inflammation as part of that problem. For example, rheumatoid arthritis, or as you mentioned, psoriatic arthritis. And these patients are at increased risk for developing thin bones or osteoporosis. And so from my perspective, I'm seeing patients that have inflammation in regard to their arthritis. And I'm always thinking about low bone density. Of course, these patients can have other conditions, including cancer, which will be the focus of today's discussion. One other group of physicians that actually might have been on this panel are the OBGYN physicians, and of course, family doctors, family physicians, internal medicine specialists also see and evaluate patients for osteoporosis.
Fantastic, thank you. And our moderator today is Dr. Melanie Goldfarb. Dr. Goldfarb is a fellowship-trained endocrine surgeon and a director for the Center for the Endocrine Tumors and Disorders. Her expertise is minimally invasive surgery for thyroid cancer and disorders, hyperparathyroidism, and adrenal tumors, including pheochromocytoma. Did I say that right, Dr. Goldfarb? Okay. Cushing's, Conn's, and adrenal cancer. Dr. Goldfarb's research focuses on quality of life disparities and clinical outcomes for endocrine tumors, young adult cancer, second cancers, and cancer survivorship. Thank you for moderating today, Dr. Goldfarb, and take it away.
Thank you, Jean, for having me, and I'm going to say being a guest moderator in this series, because usually Dr. Martin does it. But I am here with my colleagues. So as an endocrine surgeon, I work very closely with my endocrinology and honestly rheumatology colleagues because I send a lot of patients back and forth for our conditions. And on a side note, as Jean mentioned, my passion outside of the clinic is cancer survivorship. And with that, there are a lot of other doctors and clinicians that are not the surgeon or the oncologist that are really involved in taking care of cancer patients during and after treatment. I know there was a webinar on survivorship in general about a couple months ago, and maybe this will be a first out of more webinars. I'm throwing that out there for all the other things that have to do with cancer patients once they're done with their treatment. And bone health is just one aspect of survivorship that patients confront for the rest of their time as a survivor. So hence our webinar today. I'm going to go around and ask everybody some questions. Everybody has expertise. And I'm going to start with Dr. Singer, just because he's been around the longest and really a part of our Cancer Institute, to ask what bone problems develop specifically in cancer patients.
Well, I think depending on the cancer, but in general, osteoporosis is pretty common. After 30 years of experience in the Cancer Institute and seeing patients, I can't even count how many patients I've seen with bone loss after cancer, particularly after treatment of the cancer. And the other one is a worse complication, that is bone metastases, when a tumor spreads, from the primary tumor and involves the bone. That's much more difficult to deal with. And then, of course, there's some disorders such as multiple myeloma, in which the disease starts in the bone and can destroy the bone and not uncommonly raise the blood calcium. So that can be treated. But so basically, osteoporosis and bone metastases are the main problems that we see.
And so, Dr. Troum, to add on to some of what you said, your expertise was, are there cancer patients that are more at risk for osteoporosis and fragility fractures that may have other conditions?
Thank you, Melanie. So yes, there are patients that I see that because of their underlying condition, as I mentioned earlier, just from their underlying condition are at increased risk. But obviously patients with rheumatoid arthritis, lupus, and some of these other autoimmune conditions get cancer. And so when you add the underlying predisposition to osteoporosis, and then the medications, and quite frankly, for many years, and as Dr. Singer remembers, as I did, in the early 1980s, when we were treating patients, for example, with rheumatoid arthritis, we really didn't have the wealth of and really the variety of medications that we have now to treat these underlying conditions. And so these patients would get osteoporosis, get cancer, and then get treated, or they were taking, in one medicine in particular, corticosteroids or prednisone-like medicines that really bleach the calcium out of the bones and put these patients at increased risk.
Thank you. So Dr. Lynn, what are some of the signs and symptoms of bone loss that patients or their clinicians should look out for?
So this really can be a very silent disease when we're talking about low bone density and osteoporosis. Oftentimes a person may not know or may not be diagnosed unless you specifically are actually ordering a test to look for bone densities by doing screening such as a bone density, which we call a DEXA. Other things that may occur are more potentially signs of things like low calcium or low vitamin D, which can clue you into the possibility of low bone density. But I think what the important thing to do is to identify those individuals who really are at risk and make sure to appropriately screen and check out what their bone density is by ordering a DEXA scan for them.
So can I follow up on that and say, how often should you have a bone density scan when you're getting or after cancer treatment?
So yes, if a person is on treatment for osteoporosis, whether they have the history of cancer or not as the reason or underlying cause perhaps, or contributing cause for osteoporosis, we don't want to do bone density scans too frequently. The bones do change rather slowly. And so maybe the earliest might be at a year, but often we will wait more than a year, maybe even a 2-year interval in some situations before we measure a density with a DEXA again, in order to give enough time to appropriately see an effective therapy.
And Dr. Singer, are there any other blood, urine, or other kinds of tests that we may want to order to help assess bone loss in cancer patients?
Well, there are biochemical tests for bone loss, which have been developed, not that many years ago. And I think some physicians use them and others ignore them. I've used them a long time because I did some research with someone at the University of Washington, which produced the urinary N-telopeptide, fancy name, test. That could be urine or sometimes in blood. So people that are losing bone, well, let's start with premenopausal women. Their average value for this test in the urine is 35. And if they stop having periods normally at around 50, that measurement goes up to an average of 60. And that's associated with a lowering bone loss over years. So I think one method of seeing is someone losing bone, particularly if they're premenopausal, perhaps, is do they have a high biochemical test for bone loss? And then you can follow that. And then when you give a particular treatment after a few months, you can check and see if it comes down to the normal range or even a little lower. So I think, I've used that test for many years and I find it generally very helpful.
So Dr. Troum, I'm going to let you kick off this next question, but we probably want answers from everybody. So we know, and we'll talk about later, the big gun medicines for bone loss. But what are some non-medical therapies and recommendations that patients can follow to help reduce the development of bone loss before, during their cancer treatment?
Very important question, Melanie. If I could just reflect back to Dr. Singer's last comment, though, if I'm not mistaken, Dr. Singer, that was Dr. Chestnut, was that correct? At the University of Washington that you were working with at the time, Charlie Chestnut?
Well, he was there. There was a biochemist too, so yeah.
Just trying to jog my own memory, thank you. So to answer your question again specifically, Melanie, the things that can be done in order to try to decrease bone loss would be exercise and specifically weight-bearing exercise. And many may know that when the astronauts go up into space, if they don't have some weight-bearing boots or have something to make sure that their bones are being stimulated by exercise and by gravity, that they lose a lot of bone. That's one of the problems that astronauts could encounter. But for us, just typical weight-bearing exercises, and that may just include walking. The other things that are important would be sufficient calcium. This has been brought up already, the amount of calcium typically, and I'd like maybe my colleagues to comment on this. I'm typically now recommending 1,000 milligrams of calcium supplemented daily, and it doesn't have to be in pills. It can be naturally. I mean, if you're eating yogurt, a cup of yogurt, about 300 milligrams of calcium, an 8-ounce glass of milk, may have another 300 milligrams, and you can get all of this naturally by what you're taking in your normal food intake. And then vitamin D, and that has been alluded to also, the importance, Dr. Lynn mentioned the importance of vitamin D, because that helps to bring the calcium from your intestinal tract through the intestines into the bone, and it helps with the mineralization of new bone. So some simple things. exercise, sufficient calcium, vitamin D, and then to try to avoid foods or medications, if you can, that may bleach the calcium out of the bones.
What would, or any of you can answer, what would some of those foods and medications, we mentioned steroids before, but nutrition's always a big thing. So we talked about, if one of you can talk about what are some good nutritious foods for calcium and vitamin D, and what are some bad foods for calcium and vitamin D?
I'll comment here. Vitamin D comes essentially in two major forms, D2, which is ergocalciferol, and then D3, which is cholecalciferol. The D2 comes from a lot of, let's say, plants, particularly fungus, so mushrooms. D3 tends to come more from animal sources, so particularly oily fish. It's hard to get a lot of vitamin D from the diet. And so there's been lots of studies on this, but often for people who truly are low in vitamin D or who are trying to maintain an elevated level or sufficient level, it does come down to supplementation. As Dr. Troum mentioned with calcium, it's a lot easier to get calcium sources in the diet. And in terms of the amount of supplementation of calcium, I often recommend around the same, so 1,000 up to 1,200 milligrams per day, but not all at one time. It really needs to be in divided doses because the gut cannot absorb a big dose of calcium. So you really should be taking 500 or 600, but once or twice a day. And preferably, if you can get the majority of this from diet, that would be great. So dairy sources are wonderful for calcium from the diet, but also there are some leafy greens, there are nuts that can provide it. And then depending on what kind of foods you buy, there are also fortified foods such as orange juices or vitamin D milk that have additional vitamin D. Sorry, that was for vitamin D. I kind of mixed those up with the calcium.
That's okay. And what foods are, what we, Dr. Troum mentioned that bleach the calcium or vitamin D? Are there any foods that are bad to have, or is that more drugs?
I'm not aware of any particularly bad foods, but there's, certainly drugs. People using certain types of antacids don't absorb calcium very well. That's pretty common. Upset stomach is a common problem in humans. And so paying attention to the drugs that are used is important. And then there's a whole, besides steroids, there's, I think, many other kinds of drugs that are maybe not so commonly used, but basically steroids are the worst and highest offender, I think, in medicine.
So I'm hearing, and we have comments in the chat about specific doses. So I was hearing calcium about 1,000 to 1,200 a day. What about, does that change if you already have osteoporosis, if you are on steroids, if you are on, let's say, aromatase inhibitors or other sorts of hormones? Does that daily recommendation change for calcium and vitamin D?
So I think the recommendations from the official guidelines still remain in that 1,000 to 1,200 milligrams per calcium intake. Personally, so with a lot of my patients, I am recommending vitamin D between 1,000 to 2,000. I think there are some official guidelines where the recommended daily allowance for vitamin D might be officially posted as lower, such as 800. But in the people that I'm working with and patients that I'm seeing, I think 1,000 to 2,000 is a reasonable amount that will not overtreat a person, but will maintain their levels at above 30 when we measure in the blood.
Okay. What about, so I think we talked about all this, but there are some questions about, as we're on the subject, what about for women getting breast cancer therapy? We mentioned, aromatase inhibitors, and then, the other breast cancer treatment. And then on the opposite side, what about men that have cancer and osteoporosis? It might be on some other specific hormone and therapies for prostate cancer or something else that can affect your bones, calcium and vitamin D levels.
Well,
Dr.
men,
Troum, do you want to, or Dr. Singer, do you want to start?
well, men, of course, prostate cancer is the biggest offender of life, shall we say, in men. And so often they get drugs which lower testosterone. And just like in women that have low testosterone naturally or unnaturally, bone loss increases, and one does not give back testosterone if you have active prostate cancer or if you've had prostate cancer. So one needs to defend the bone with a variety of medications, which we can get to. So men given cancer chemotherapy, of course, can lose bone. I think one of the issues that I see is not always followed. If you detect cancer and the patient is going to be treated, with chemo or aromatase inhibitors, I think all of those patients should have a bone density test. I don't care what age, because you don't know what somebody's bone density is. Genetics play a major role in what your bone density is. So if your mother and or father had a low bone density, the chances are one or more children could have a low bone density. So I think any cancer patients that is about to receive therapy deserves to have a bone density test to see where they start. And so depending on that, I guess if you had wonderful bones, you might not necessarily have to start some kind of anti-osteoporosis therapy, but seldom is that the case. One would want to prevent. So prevention is totally doable, but you need to know the bone density.
Dr. Troum, you look like you want to comment.
I think that's very important. And Dr. Lynn also had pointed this out before. We don't really know where we're starting from. And I totally agree with Dr. Singer that I typically, for my patients just entering into menopause, I ask them to get a bone density to know where they're starting and then know how aggressive that we may want to take it, besides the things that I had mentioned earlier, the exercise, the sufficient calcium, vitamin D, and the others that have commented on, but whether or not other therapies that I'm sure we'll get to would be indicated. But this is also an issue for men, as Dr. Singer pointed out, although typically later for my patients that don't have cancer, my male patients, they're in their 70s and 80s, I also offer them and recommend that they get a bone density test because of loss of testosterone. So these are important things and can be checked for. And as Dr. Lynn pointed out, this is a silent disease. You don't know that you have osteoporosis unless it's looked for, or you have your first fracture and then it's looked for. And by then, the first event's already happened and it might have been prevented.
So Dr. Lynn, we have some questions. Can you take too much vitamin D? And also to kind of clarify, you talked about the difference in D2 and D3. Do you need to take different do you need to take both of them, or will it all sort of work itself out?
Right. So in terms of the D2 and D3, when we're measuring vitamin D levels in the blood, it's actually measuring both things. Most of the trials of vitamin D have been with vitamin D3, which is the cholecalciferol. And so if someone wants to follow something more evidence-based, then you just buy D3, and it's very easily available over the counter. And so when I'm seeing people and we're talking about bone health, we're seeing someone who has a low vitamin D level in the blood, I'm recommending to them to go and purchase D3 over the counter, 1,000 to 2,000 IU for a daily dose. I've noticed over time that on the labels of these bottles, they have changed over time to reporting them as mcg, I believe. So 25 or 50 or 100 is commonly reported, but they will also give you the equivalent of the IU, which has just been kind of just more in my head in my practice for a long time. And I'm going to start to transition to the other measurements just for ease. In terms of the dosing, you do not have to split the vitamin D in multiple doses. You can simply take it all at one time. if you need to take it with food or without food. It may not make a huge difference, I believe. Dr. Singer or Troum, correct me if this is wrong. So vitamin D is a fat-soluble vitamin. However, it doesn't mean that you absolutely have to take it with a fatty meal. It can be taken regardless of food intake.
Thank you. And what about, can you ever take too much vitamin D?
Yes,
So,
you can. You could go ahead.
Oh, yeah. So I think we probably would have the same answer. Yes, there have certainly been cases. There was a case report, I believe it happened in Europe. I don't remember in which decade, but there are countries that fortify vitamin D in a lot of foods. So lots of foods with extra vitamin D. And there have been reported cases where people had excessive vitamin D and actually got intoxicated. And what that results in is that they actually had too much calcium in the blood. And the high calcium as a result of too much vitamin D actually can cause a number of problems, the most common perhaps of which are kidney stones. So it is possible. So it's not a good idea to just take high doses of vitamin D and not be monitored.
It's said that 10,000 units is a no-no. So you generally need less than 10,000. But the other thing is that what we've learned in recent years is that obese people tend to store vitamin D in their fat cells. And so someone that's obese may need to take more than the usual 1,000 to 2,000 units a day. But you would have to, you might get 4,000 or 5,000, but you would need to measure the blood just to be sure you're getting the number we use is 30, greater than 30 as a desirable level of vitamin D. So obesity, which is not rare, can affect how much vitamin D someone should get.
So you just mentioned a specific topic. Maybe Dr. Troum can answer. What about men and women? Are there different dose recommendations for both vitamin D and for calcium for men and women to add on to the difference in obesity?
So in general, no. In lactating women, there may be a slight increased need for calcium. But I think both Dr. Lynn and Dr. Singer pointed out something very important in that it is very important to monitor the level. So you don't know, again, unless you check what the vitamin D level is. One other important aspect of this, at least in my practice, and I'm sure for Dr. Lynn, who's seeing patients that come in and complain of fatigue and being weak and having muscular problems, certainly in my practice as a rheumatologist, where I'm evaluating these patients, one of the causes for muscle weakness and for fatigue is very low levels of vitamin D. And obviously that will also translate into problems for bone density, because as we talked about earlier, you need that vitamin D to help the calcium get into the bones. But that's an important thing to check. So people with very low levels of vitamin D actually may be helped just by replenishing their vitamin D. And like Dr. Lynn said, I typically use vitamin D3 for supplementing patients their diets if they're lacking it.
The one reason we like vitamin D3, that's the natural vitamin. It has a longer half-life than vitamin D2. So basically, I think vitamin D2 should vanish from use because the sunshine that hits your skin makes vitamin D3. You might as well go with the most natural form.
If I could just add one other thing, Fred, and I appreciate you bringing that up, because we can get vitamin D3 through sunshine, from getting sunshine. So I used to recommend to my patients that they be out in the sun. Now the dermatologist is telling me not to make that recommendation so much, since we're talking about cancer and melanoma and other forms of skin cancer, that really the significant risk is too much sun exposure. So that has to be tempered with maybe supplementing vitamin D orally, as well as getting maybe a short amount of sunshine.
Agreed.
So before we get into talking about different drugs to treat osteoporosis and other bone loss, I want to kind of just ask, we know that, there's what we call metabolic osteoporosis, or osteoporosis that can come from genetics, other things. Is osteoporosis from cancer treatment, and I'll let all of you kind of comment on, is it only chemotherapy, or is there other cancer treatments that can cause osteoporosis? Is it different, or is it all kind of just end up being the same thing with the same treatments? So I don't know does anybody want to kick that off?
I think it's generally similar. I don't think we can distinguish much, in terms of the actual bone problem.
I would echo that. I would say that the endpoint that we're trying to prevent with osteoporosis is fracture. And Dr. Singer mentioned earlier about metastases, that there's other treatments, or at least some of the similar treatments that we use for example, postmenopausal osteoporosis that we might use to prevent metastases by blocking the certain cells that excavate the bone, the osteoclasts. We'll get into that discussion. But the bottom line is that you're trying to prevent fractures from occurring, and the underlying mechanism may be different, but the endpoint that we're trying to prevent is the same.
And so
my comment.
Yeah, Dr. Lynn, go ahead.
Yeah, so how do we diagnose osteoporosis? It's basically by meeting criteria on DEXA, by having a very low T-score, which is how many standard deviations the bone is away from a healthy young individual, or by having a elevated FRAX score, so a calculated 10-year risk, putting a person at high risk of fracture, even if their T-score doesn't quite meet a numerical criteria, or in a person who we've diagnosed as having a fragility fracture. So there are a few ways to diagnose to actually put that diagnosis of osteoporosis. But again, it doesn't differentiate as to how a person arrived there. And for the most part, neither do the drug therapies that we're able to use differentiate how a person got to that point.
And just to add on to that, I know that chemo, and we talk about cancer, right? This is a cancer talk, and we know that chemotherapy is a risk factor for bone loss. Are there other types of cancer treatment or different kinds of cancers that put patients at risk for bone loss?
Well, the treatment of, breast cancer patients is to reduce estrogen. So anti-estrogen drugs are used extremely commonly, and they tend to increase the rate of bone loss because there's extremely little estrogen circulating if you're on anti-estrogen. So that's a big producer of bone loss in breast cancer patients.
Okay, so maybe Dr. Troum, you can start with the next as we start talking about therapies for bone loss. Most people want to know, what is the difference between all of them? They know there's some bone building drugs and there's some prevention bone loss drugs. Can you give a very brief overview of what the different medicines are that you clinicians have at your armamentarium?
I will try to be brief. Thank you. So, it was not until 1995 really that we had any other therapies other than what we've already spoken about. Estrogen, testosterone, normal and natural hormones that can help the breakdown of bone. And if they're in sufficient levels in our bodies, that's helpful. Calcium and vitamin D, all helpful. Exercise, helpful. It was in, I believe, November of 1995 that alendronate, one of the bisphosphonate medications, of which there are several, a few of them currently being typically used, that block one of the two cells. Typically, there are many cells that are involved in bone metabolism. But in regard to osteoporosis, there are medicines that block the excavator cells, the osteoclasts. And then there are medications that build up or promote the bone building cells, the osteoblasts. And there's the most recent of these medicines that actually is a combination of both of those. In general, the majority of patients that I start on therapy are using bisphosphonate therapies. And this is similar, and maybe Dr. Singer, Dr. Lynn can also speak to that in regard to patients with cancer. But certainly the bisphosphonates and the brand names, for example, might be Fosamax or Actonil. There was Boniva available and intravenous reclast. It's given once a year, and they block the osteoclasts. The medications that subsequently came, the daily injections, of which there were two brand names, Forteo and Tymlos, stimulate the bone building cells, the osteoblasts. And then most subsequent to that, there was another medication that also blocked the osteoclast, an injection given twice a year, denosumab or Prolia, also used in treating patients that have cancer and for their osteoporosis and even for the metastases that Dr. Singer alluded to earlier. And then the most recent of these medications has the combination of both stimulating the bone building cells and blocking the excavating cells, the osteoclasts, and that is Divinity, and that's the most recent of the medications that I'm aware of. I hope that was a quick overview of the medicines that are currently available.
Listen, it's all confusing for me because I hear about them and I get them all confused anyway, so it's all good. So to build on that, Dr. Lynn, if you're a cancer patient and you're already on a medicine for osteoporosis, and now you get diagnosed with cancer and you're going to get one of these therapies that are supposedly make your bones worse, what should you do? Do you need to switch medicines? Do you need to add medicines? Is there anything else you can do, or you just hold the course?
So if you were diagnosed with osteoporosis first and you started drug therapy and now you have this cancer diagnosis and maybe you're being told that part of your treatment will be a drug, maybe high dose steroids that can worsen the bones. It is really important to make sure that you are in communication with whichever doctor, your endocrinologist, your rheumatologist, maybe your primary care doctor, who is managing your osteoporosis drug therapy, because at this point, then maybe you want to do things like have bone turnover markers measured to give you an idea of what's going on with your bones as you start the cancer chemotherapy drugs or the steroids. Again, the bone density won't show changes that quickly. So there is a potential for change in therapy, but I don't know that it would be advised just simply with knowing that a person's starting a chemotherapy. But you need to see if your bones are worsening at a more rapid rate, then maybe that is an indication to change therapy. Or if you sustain a fracture with the introduction of the cancer treating drugs, maybe that's an indication to change your osteoporosis drug to something else.
And with that, maybe you can answer, if you are one of these people that you think you're more complicated, you have osteoporosis, now you get a cancer diagnosis, or you have a strong family history of osteoporosis, you get a cancer diagnosis, you need chemo. Do you guys think it's important to maybe have a consultation with a specialist like one of yourselves? We mentioned that primary cares, OB-GYNs all regularly manage some basic osteoporosis, but I think in this situation, you feel that a consult with a specialist is important?
I would definitely feel so, because there are certain drugs that I think those of us who are specialists are more comfortable prescribing and are able to prescribe and actually administer in our offices.
I would second that, but we're kind of begging the question, Melanie, but I think it's important to have a good team approach. And I think that's what St. John's is all about, that we have access to each other, to these specialists, and we can communicate, freely, and we do, in trying to get the best outcome for our patients.
Great. What about, and again, because we're getting some questions on all the different medicines, Dr. Singer, maybe you can start. What would make you choose to start one type of medicine for the other? We heard the bisphosphonates were one of the first medicines. We all know the word Fosamax, it's lower cost, so on and so forth. What would make you choose one of the newer, I'm going to say more powerful drugs than just Fosamax for a new patient?
Well, that's Good question. Maybe no perfect answer. For instance, Dr. Troum nicely reviewed what are all the treatments. So we could just divide it into mainly a treatment that prevents bone loss and treatment that increases bone. The problem is I haven't seen very many studies, if any, in cancer patients giving a what we call anabolic agent, which is something that stimulates bone. That might be dangerous in a prostate cancer patient, who might have metastases that could cause trouble. So basically, in most of the patients, we're using anti-resorptive or bone loss preventing drugs. But I think maybe there ought to be some studies on anabolic drugs in people with severe osteoporosis, but I really haven't seen that. So what I would say is that the drug Prolia, which is not anabolic, but given over many years, 10 years of every 6-month injection of Prolia, although it's not making new bone, it increases the bone density on the average 20%, which is pretty significant. So perhaps with the more severe kinds of osteoporosis patients, if they weren't getting Prolia when they start chemo, maybe at least it would be interesting to think about Prolia as a help. But I haven't seen studies, but it just makes sense to think about that.
If I could make a comment to that, Melanie and Fred, it's so important because I have been doing clinical trials as many of our colleagues have as you guys, but one of the exclusions for participating in clinical trials for a diagnosis, for example, of osteoporosis is having had cancer. So that completely shuts out that whole population. But your point is so well taken that there should be some directed studies in our patient population for our patients that have cancer to give us the answers, because without the studies, without the double-blind studies, we don't know the true answer to that. But as you mentioned, I mean, Prolia has done such a good job, denosumab, and in actually the head-to-head study against alendronate or Fosmax, it did better in just postmenopausal osteoporosis, as we know. So fortunately, we have these therapies to help us with our patients with cancer and for those that don't.
So let me just pivot for a second. We have a lot of female-focused questions, so I want to ask a few of them. Dr. Lynn, maybe you can start this off. So there's some questions about, are there certain types of surgeries like having your ovaries removed, your breast removed, your uterus removed? Can any of those affect your risk for osteoporosis, or how well any of these medicines work? Do we need to be more aware or do anything differently?
Certainly, yeah. So the ovaries are the organs that produce estrogen. And in the kind of natural course of aging in women, the ovaries go through ovarian failure at a typical age of something greater than age 45. And when we lose estrogen, we have an increase in bone resorption. So if you were to have your ovaries removed and you are already postmenopausal, that doesn't make a huge difference because you've already gone through that estrogen loss. However, if you have your ovaries removed at a younger age before you've naturally gone through menopause, then you're prematurely going into menopause, and that can happen surgically or medically, but most commonly in answering the question with an ovarian surgery to remove those. So that would be certainly at putting a person at higher risk.
So do those patients need to start medicine, or they basically should just go in, get their bone density checked, and go from there?
Yeah, so some younger women may actually go straight on to hormone therapies with their physician because of their young age, and then perhaps transition off at a more natural age of menopause. So it's not an absolute reason to start an osteoporosis drug right after ovary removal in most circumstances.
Okay, great. So I'm going to call these some housekeeping questions, but Dr. Troum, you've had bone density at one institution or one facility for 15, 20 years. Is it okay to go to another facility, or is the best, does it really make a difference where you get your bone density stuff done?
I think intuitively, you would think that it's best to have it done with the same machine, not necessarily just the same institution, the same machine. And the really key here is not just having the same machine, but maybe even having the same operator or the same person that's doing it, because it varies. There are a few different machines that are typically used. There are different ways to measure bone density, both with conventional bone density machines. There's also a CAT scan way to do that. But to answer your question, it's best to do it at the same place, same machine, and with the same bone density operator if you can do that. If not, I think just personally, I don't know that there's data about this, and maybe my colleagues can correct me or add to this, but it's best to use the same type of machine. So for example, the brand names might be a hologic machine versus a General Electric machine. If you could use the same type of machine, I think you would get less variation of the numbers. But if you can, same place, same technician to do it would be the best.
And Dr. Singer, what about IV medicine versus oral medicine? We started to talk about that. Is one better than the other? And
well, I think oral medicine, if we talk about the most commonly used over the last 20 years, that's Fosamax, or alendronate is the generic name. That in about 5% or so of patients causes heartburn. And I don't think telling people to continue that is a nice thing to do. So in that case, one could transfer to intravenous, reclassed, or zoledronic acid. It was approved as being given every year for 3 years or more. My experience, and that from New Zealand, is that one infusion of reclassed prevents bone loss for up to 5 years. So people with mild changes in bone density, theoretically, could receive one infusion of reclassed and then follow the urinary biochemical marker. I've done that for many years, and generally it's been satisfactory. Of course, then if you could take Prolia, which is an injection, but that's far more expensive treatment, very effective. So I think each patient is different. It depends on their insurance, what their mental state is about getting an IV. Some people said, oh, I don't want an IV infusion. The danger, oh, by the way, the use of drugs, any kind of drugs, is inadequate in the population because of fear of side effects, which you read in the FDA little inserts, which are incredibly exaggerated. So, I mean, I have to explain to each patient, oh, I read that it can do this and that. And I said, well, that's like in 1 out of 10,000 people, like the jaw problems and things. So there are different medicines, and one has to, and different attitudes in the patients. But the fact is 20% of hip fracture patients get treated or even have a bone density after a hip fracture, and that's pretty terrible.
so we have a lot of very directed questions in the chat box, which we're going to answer afterwards. So my last general question, I guess I'll let Dr. Lynn finish it up as a follow-up. We mentioned drugs like Prolia and Reclass. There's been a lot of talk lately about, can you stop it? When should you stop it? And what happens after? And I know that it's a long answer, but in brief to patients, what do you tell them?
So when we talk about Prolia, I do let patients know that there is a published study of patients who've been on Prolia for 10 years. So good data. I think Dr. Singer or Dr. Troum might have mentioned this. So we expect it to be a long-term therapy. If you're going beyond 7 or so months, so you're missed your 6-month mark and you're now at 7 months, there is concern for worsening resorption. And so you really don't want to miss your doses, or if it has to be missed. This came up with the onset of the COVID pandemic. If you weren't going in the office, then there was discussion of perhaps going back to a oral drug to bridge that time until you got back on something like a Prolia shot. With the bisphosphonates, there is the possibility of discontinuing after a shorter number of years and perhaps going on a drug holiday, meaning coming off the drug, monitoring biomarkers or bone density, and then potentially resuming that same drug at a several years holiday, perhaps.
Thank you. I don't know if it's a good or bad thing that we made it until the last question without mentioning COVID. So I'll leave it at that. But I'm told our time is up. So I really want to thank all our panelists for, I think, giving a pretty good introduction to bone loss and cancer patients and all of, as you can tell, the complicated aspects of monitoring and treatment. Like I said, we will get to all the questions in the chat box. A lot of them were just very specific. So I wanted to keep this more general and applicable for everybody. So thank you. Jean, are you supposed to say something at the end, or is this me?
I'd like to say something, and thank you very much, Dr. Goldfarb. I appreciate that. And thank you to all of the panelists. This was really interesting and really informative. It's incredible how things change and the new opportunities that come, with the different drugs that are available to us. So this is really, it's fascinating information. Thank you very much for your time and helping us with this. And as Dr. Goldfarb mentioned, we will be following up with questions that were not answered. We'll be sending you an email in the next week or so. We're going to, pose these questions to the doctors, get their answers, and then we'll send them back to the whole group along with a link to this webinar. So if you want to share it with anybody, you're more than welcome to. So please look out for that as well. That'll be coming in your inbox shortly. So I just want to thank you again, panelists and everybody, for joining us. This is great information on bone health and the importance of vitamin D. And St. John's Cancer Institute has a long history of treating and researching cancer, and also speaking about the different issues that can come up from your treatment. So, we are going to continue these webinar series. They will be, we'll have a couple more this year. One will be in October. It's actually going to be a little different than we typically do on October 26th in the evening. Our breast team of Janie Grumley, Crystal Fadcher, and Parvin Petty will be hosting The Power of Pink. It's going to be a live virtual event that will speak to the latest on prevention, treatment, and research in breast cancer. You're going to be hearing from courageous cancer survivors. You'll be entertained by some special guests, and you'll be have a chance to win a gift from one of our sponsors. So please mark on your calendar October 26th from 6 p.m. for The Power of Pink, and you will be getting information about that. And as it is Breast Cancer Awareness Month, I wanted to let you know that we are going to be lighting the hospital up in pink for the month. So it's beautiful, and that will be all of October. So please drive by and see it. It's beautiful and it's meaningful for those of us that have been, for all of us that have been touched by breast cancer. In November, on the 16th of November, from 12 to 1 in the afternoon, we'll also be talking about lung cancer, some of the changes that we've seen in the last year or so, treatments and research in lung cancer with Dr. Robert McKenna. So, I just want to thank everybody for being here and your support, and just know that we can't do this work without your support. Thank you for considering how you may help us in supporting this critical work. You can go to our website and donate there, or you can respond to the emails that we've sent you, and I'll be very happy to get back to you as well. And we hope that you will join us on future webinars. And thank you so much for being with us today. We'll see you again soon, we hope.